Good morning, good afternoon, and good evening. Welcome all of you to the live program number 172 at Orthopedic Principles. Today, our guest of honor is Dr. Thiago Busato from Curitiba, Brazil. If you remember, Dr. Busato has earlier lectured with us, and that was a fantastic lecture and well received by the audience. Dr. Busato has been to the Bernese Center in Switzerland, where he learned the art and science of hip preservation. And today, Thiago is going to enlighten us on hip arthroscopy, avoiding complications, and improving the operative field. Over to Thiago.
Okay, Professor Gopal, thank you so much for inviting me once again for your continuous educational program. It's an honor. As Professor said, I'm going to talk a little bit today about hip arthroscopy. These are my disclosures. And this is our teaching hospital in Brazil. I live in Curitiba, which is a city in the southern Brazil. So we're going to go through a little objectives in this lecture about how to avoid complications. And first, we're going to define the problem. We're going to talk a little bit about how to mitigate those risks. And finally, share some tips and tricks to improve the operative field. These tips and tricks were collected on the last 14 years that I've been practicing hip arthroscopy, and among some of our colleagues, arthroscopists in Brazil. So I think there's a lot of practical tips, very interesting for the hip arthroscopists. So avoiding complications. The historical rates range about 15% on the original series by Professor Jim Glick from the United States, which is the one who pioneered the hip arthroscopy. Nowadays, it seems to range something between 6%, but there's an interesting aspect that it changes with your learning curve. I mean, as you're gonna get bolder, the complications change. You start to perform more complex surgery, the type of the complications will change with your learning curve. It's interesting. And there's a recent meta-analysis with 36,000 plus cases that identified only 0.16% of major complications. So most of the complications are transient, thankfully. So we can divide it into three categories, which is the avoidable ones, like scuffing of the femoral head, mostly, iatrogenic labral lesion or penetration, the most common one, which is insufficient correction, and the other aspect that is excessive correction. We have some minimizable ones, like traction table related complications, neurological complications, femoral neck fracture, vascular necrosis, adhesions, and instrument breakage. And we have that type of complications that are always potential, like infection, heterotopic ossification, and fluid starvation for the abdomen, also VTE. So let's talk about each one of these complications. The first one, scuffing. For sure, it's underreported. I have a doubt that there is any arthroscopist that never had one case of scuffing on his life. So this type of complication is very underreported. It's related to difficult access to the joint, like on male, more muscular patients with major pincer type in FAI. When you have some difficult times to really distract effectively the joint so you can enter the interarticular space. You can avoid it doing a traction trial, effective traction before you start the surgery itself. You always should use a two fingers technique, which means you cannot be forceful in hip arthroscopy. If you are using force, something wrong is gonna happen. And you also can plan your portals, like I said before, in the pincer type. You can go a little bit distal so you have a better approach angle for the joint. And my preferred technique, which is outside in, which means I start without traction, I open the capsule, and then I go inside the joint. I'm going to show you some videos of this technique on the end of this lecture. Labral penetration, how to avoid it. First, you have to watch out for hypertrophic labrum, especially on dysplastic or borderline dysplastic hips. And you can use the safe technique that was described by Don, which have some steps. First, you do an injection of air inside the joint. You take the needle out, and then you enter it again with the bezel facing up to avoid the labrum. Then you turn the bezel for the femoral head to avoid scuffing, and insert the nitinol guide wire, and so on. Insufficient correction, I said before, this is the most common cause of revision arthroscopy. So this is from the series of Philippon. 95% of his revision arthroscopies was due to insufficient correction. And also labral lesions, 85%. How to avoid it? On the CAM type, we suggest a previous planning with throughout imaging studies, like if you feel more comfortable even with a CT, with a 3D reconstruction, or even with a 3D printed model, so you can really understand where you have to remove the bone. You should always use fluoroscopic control, especially in the beginning of your experience, because you often you think you are in one spot of the head, but you are lost sometimes. So dynamic examination is very important, it's crucial. And another tip is to look for drenation pits. If you see drenation pits when you are doing your osteochondroplasty, you're probably on the right place, because they are related to the CAM impingement. Another tip, the residence ridge. This is famous on the knee for reconstructions of the ACL ligament, but there is one on the hip too. This was described by Matsuda. This is the image he called it the residence ridge. So what is that? Is the most medial aspect of the femoral head of the CAM. You may be satisfied with this correction that you are seeing, but there is a lack of offset on that region. So this is the perfect correction, and often goes missed in the beginning of your learning curve. Decessive correction could also cause a loss of the articular seal effect, which is probably the most important function of the labrum, and also carries a risk of femoral neck fracture. So if you create a huge defect on the femoral head, when the patients do a flexion movement, this defect will enter the seal, and he will suffer for micro instability. On the beginning of hip arthroscopy, we were much more aggressive with these resections, but nowadays we are trying to identify and to remove just the necessary of the CAM type impingement. And how to avoid it on the pincer side. So this is a nice view. This is called the upper deck view. When you enter the supraacetabular space and you look distal, this is a common mistake. You made a correction to the right of the image, but there is still a strip of bone underneath the labrum. So this is the look that you have to avoid. This view, the acetabulum should look like a wall, not like a wave. Instability is a common complication, not always gross, as this is of this image that was published by Matsuda, but micro instability is common. This can be caused by excessive ring trimming, hyperelasticity, or extensive capsulectomies. So it's a major pitfall, mainly in female patients with what we call borderline hip dysplasia. So how to avoid it? You should template how much bone you want to take out. You can use this kind of template you draw on the fluoroscopy. You should do an active search for subtle dysplasia, as I mentioned before. In this case, a limited capsulotomy is more indicated, as well as capsular closure. There's a trend, a recent trend, to close every capsule in every patient. I'm not sure if this is correct, because we still lack of evidence for that. But for sure, in patients with instability risk, the capsular closure must be performed in all cases indeed. And another aspect is that zona orbicularis must be preserved, because it acts as a constraint on the femoral neck. You should never extend your capsulotomy distal to the zona orbicularis. This is the aspect of capsular closure. So in the future, we probably gonna have some more tools. This is in development yet. So navigation and computer-assisted surgery could help us to better understand the corrections during the operative time, but it's not a reality even now. We have some complications related to the traction, like cutaneous lesions. So we have to protect very well the feet and the perineum. It's relatively common, a transient praxis of the pudendal nerve, and it's more related to the force of the traction, not to the duration of the traction. It's interesting data by Glick. So how to avoid these problems? We should use these huge, well-padded perineal posts with a lateral vector of force. The post will act more against the thigh itself than the groin. The position of the patient is important, with a slight flexion and abduction of the leg, a slight Trendelenburg position of the table, and a slight contralateral side, so you can make a contra force for the traction, and this will alleviate the pressure on the perineum. And you should not exceed 2 hours or 20 kilograms of traction. Some tables have a sensor of the traction. And you do a traction trial before you start the preparation. The patient is already sedated, and you do the trial. You should release the trial to diminish the time of traction. Then you do the whole draping, and then you start the surgery. You do the traction again. Some nerve injuries. The most common is some branches of the lateral femoral cutaneous nerve. This is caused by the anterior portal. We recommend a blunt dissection after you do the incision. Sciatic nerve injuries are very rare. Actually, they were more related to the posterior portal, but we barely use it nowadays. The femoral neck fractures were more common on the past too, because those aggressive resections of the cam that I mentioned. So we use crutches for 3 or 4 weeks after the cam correction. We should limit the resection mostly up to 30%. You do not should remove more than 30% of the diameter of the neck. This is a classic paper from Mardones from Chile. And you also should avoid lateral cortical notching. What I mean, you should not extend the resection too further distal, because you're gonna notch the lateral cortical of the neck, which is subjected for high tension forces, and will be a risk factor for fracture. AVN, it could be caused by excessive traction, maybe excessive fluid pressure, but in my opinion, probably they are iatrogenic, caused by over-resection of the lateral type of cam. You could damage the retinaculum. So this is a picture from our first lecture. This is a surgical hip dislocation, and you can see this lateral extent of the cam impingement is right above the retinacular vessels. So if you do not know this anatomy in details, you could easily over-resect and damaging those vessels and causing an AVN. So watch out. Adhesions, they are more common than we think. There's a nice paper from back which he identified 35% of adhesions in arthro MRIs, but they are quite always asymptomatic. There is only a small percentage of patients that will have pain or limitations, but they should be probably rescoped for the lysis of these adherences. You have to avoid it doing immediate physical therapy, and maybe CPM could help too. This is an arthroscopic view of adhesion. The instrument breakage nowadays is a rare complication because of the modernization of the technique itself and instruments. You should avoid it by gentle manipulation, especially with the nitinol guide wire. Some people think they never break, but he could break. You should avoid the kinking of the extremity of the nitinol. And you should always use prime quality instruments. This picture is of a point of a trocator that just got loosened during the surgery. It was not welded for some mistake on the factory, but this kind of things could happen. Infection is very rare. We use something about 20 liters of saline, maybe even 30 liters of saline. So you are always washing the joint. But there are some sparse reports, mainly about superficial infection of the portals. And it seems that a single shot antibiotic could do the job for a prophylactic of the infection. I use still 24 hours of prophylactic. Heterotopic ossification could be up to 40% on the literature, but it mostly varies from 1 to 6%. It's caused by muscular trauma and osseous debris that could implant on the muscular. And how to avoid it? We should always wash the joint very thoroughly, especially in the end of the correction of the cam impingement. I use a prophylaxis with a COX-2 selective NSAIDs for 14 days. Abdominal compartment syndrome, it's an inherent risk of arthroscopy. It's rare. We have some sparse reports too, even with some deaths on the literature. So it's related to pseudoacetin release, so to acute fractures of the acetabulum, extended surgical time or extensive capsulectomies, and pumps with higher pressure. So you have to be very careful to avoid it. The clinical signs is abdominal distension. The pump could not maintain the pressure. The patient start to develop hypothermia, hypoxemia, and hypotension. And how to avoid it? So you should always palpate the abdominal wall. You should be aware that any changes on the aspect of the belly. If you're gonna do a pseudoastenotomy, do it at the end of the surgery. It's very rare to do it nowadays. You should try to minimize your surgical time and avoid pump pressures above 60 millimeters of mercury. And what to do if it happens? You should stop the surgery immediately and call a general surgeon to evaluate if it's going to need to open the abdominal wall or just do a medication and punction sometimes. There are two types of arthroscopic pumps. This is curious because some manufacturers have an articular calibration type, and the other ones have a gravity equivalent type. So you have to know what is the system that you are using, because the pump could mistake you with the measures. The articular calibration type could overestimate the pressure, the real pressure on the joint, by 10 millimeters, and the gravity equivalent is more dangerous because it could underestimate the pressure. So it's important to know if you change the manufacturer from one hospital to another, but I always use the same, so for me it's not a problem. VTE is underdiagnosed, probably because we usually just do a screening in symptomatic patients, but there are some sparse reports. There are no specific guideline. You should do a case-by-case decision. I have been using aspirin for my patients for 2 weeks, but it's important to try to stratificate your patients. Maybe in obese patients, you could use something more strong. There are some pitfalls. This is one fundamental paper. I always show this paper. You have to know when not to perform a preserved surgery. Femoral torsional deformities are very common, and roughly 15% of painful hips in young patients have some kind of torsional deformity. You have to look for it. Instability is a cause for failed hip arthroscopy, so you should search the Baton criteria. Borderline hip dysplasia, it's danger because one X-ray like this could easily go missed. You have to look for the signs of mild dysplasia, like this case. This is one case that we performed a PEO, not an arthroscopy. And finally, some tips to improve the operative field. This is the kind of image we all like. It's clear, you can see everything, but sometimes you have a red circle, right? Sometimes you have a white one, and even worse, sometimes you have a black one, so something burning on surgery. So how to avoid it? My routine is spinal plus general anesthesia for all my patients, spinal for analgesia, and general anesthesia for hypotension and for better muscular relaxation. Is very important so you can achieve a nice traction. We always try to keep our systolic pressure below 100 millimeters of mercury, but in general anesthesia, the pressure is always something like 80, 90 millimeters. I use 1 gram of IV tranexamic acid in all my patients. I talk about the position of the table in Trendelenburg position, a little bit of contralateral side, the eccentric well-padded post. My pump settings are always pressure about 40 or 50, depending on the case, and an influx of 800 millimeters or 1 liter, something like that. We should try to use the smallest portals that we can because it creates like a seal and it helps to maintain the pressure in the joint. And I always start with the pincer correction, then I do the traction, I do the interarticular time, I do the suture of the labrum if I need to, and then I release traction, I do the cam impingement. This is my routine. With this type of routine, you use traction for like 20 minutes, half an hour maximum. So that's, for me, the main advantage of the outside-in technique. We have this type of traction table, which is very useful because you can remove the feet of the patient to do the dynamic testing. But if you don't have it, you can use a nice traction table too, there's no problem. This is my usual set of the operating room. The C-arm goes between the legs. These are my portals. We use mainly the anterolateral portal and the mid-anterior. And when I need to do the suture of the labrum, I use the anterior portal as described by Bird. Posterolateral portal is very rare nowadays, as well as the distal accessory lateral portal. This is a short case. This is the tenotomy of the pars reflecta of the rectus femoris. Then we open the capsule in an inverted L position. This is a case of subspine impingement. You can see how big is the anterior inferior iliac spine. There is also a calcification of the labrum. Then we are showing here the cam lesion. It's very extensive. You can see that I'm not using traction. This is the upper deck view. So I work in upside the acetabulum. This is the aspect of the labrum after the correction. And this is lateral aspect. You see how it looks like a wall. It should be vertical. This is the interarticular aspect. There was a carpet lesion. It was debrided and sutured. Then we release the traction and turn our attention to the cam side. I usually start at the upper limit of my resection. The physio scar is a nice point of repair, and this is the dynamic test at the end of the surgery. This is the preoperative versus the post-operative images of this patient. This is another case, another tip for this kind of patient with severe pincer type and also with a lateral cam impingement. We should start with the classic position. I'm using the scope at the paratrochanteric anterior portal and the instruments by the mid-anterior portal. We start doing the pincer, as I mentioned before. As we progress to the more lateral position, the access becomes more difficult, so you have to invert your portals to access the 12th hour of the acetabulum. It's easier. I'm going to show you this in a second. This is the aspect of the after the correction. You can see there is still a calcification on the labrum. So now we inverted the portals, and now I'm looking for posterior direction, so we can now access the more lateral portion of the pincer. If you think on a clock figure, it's going to be like 12 hours to 1 hour of the clock. And this is the result after the pincer resection. So we start to work on the lateral cam. Those types of lateral cams, you should work under a little bit of traction because the lateral cam lies beneath the labrum, so you won't see it entirely if you do not apply some traction, as you can see here. So the cam resection is like the other case I showed you. And this is the final results. So this type of lateral lesions are a little bit more difficult because you have to switch portals and the image changes a little bit. Well, the take-home message, so you have to, first of all, you have to do a careful patient selection and a throughout image analysis to allow for a correct diagnosis and a correct indication. This is fundamental. You have to respect the learning curve and do an active prevention of the complications, and always pay attention to details. I still nowadays, I am the one who position the patient. I am the one who pads the central post. That kind of care is very, very important. Even if you work with fellows, I think you are the surgeon. You should be responsible for these details. And just a little bit of few pieces of advice to finish. I think you should learn the general arthroscopic technique in another joint, because the hip is really difficult to learn arthroscopy. It's very small, it's very tight space. You don't have the freedom of motions that you have in a knee or in a shoulder, for example. So I think it's probably best to master arthroscopy in another joint, then go to the hip. And it's a teamwork. You depend on a nice anesthesiologist. You have to have at least one good friend. So finally, it's strongly dependent on hardware. You cannot do a good hip arthroscopy if you don't have a good traction table, if you don't have a good fluoroscopy, and if you don't have good instruments. You are strongly dependent of hardware in this type of surgery. That's it, Professor Gopala. Thank you so much.
Thank you, Thiago, for that. Thank you, Thiago, for that fantastic presentation. A few questions. Thiago, what is the size of the scope you use? Is it a 4 mm or a smaller one?
It's a 4 millimeters, and I use a 30 degrees scope. People who do the inside-out technique use a 70 degrees. But 30 degrees is much easier to understand because you're looking almost in front.
So your standard knee arthroscope is more than enough, isn't it?
I'm sorry?
Your knee arthroscope, your knee scope should be fine, isn't it, for the hip?
Yeah, nowadays I think so, because the hip scope is a little bit longer. But in this technique, the outside-in technique, a knee scope could do the job in skin patients. In the more obese patients, I think you should have a longer scope.
Thank you for that. And do you like to inject saline initially and look for a reflex so that you know that you're in the joint or something like that? Because you can do it in ankle.
Yeah, the first step of my technique is to create the paratrochanteric anterior portal. So I insert the scope and I turn on the saline. And when I'm doing the mid-anterior portal, the saline is already pumping and creating that space. So the next step would be to enter with a shaver, and I can touch both instruments inside. And then we are on that pre-articular fat pad of the hip, and the space just opens itself with a little bit of patience.
And Thiago, see, we have a lot of people watching our channel, and we have like residents, fellows, professors, senior consultants, etc. So if there is a young adult, young surgeon who wants to start with a hip arthroscope, what is the ideal case you would choose?
Yes, very, very good question. I was talking about it a few 2 days ago with my fellow. The disease patient is a patient with not complex anatomy. It will be a female patient because they are more easily distractible. The hip, you can open it much more easier than a muscular guy. And probably you should have somebody who has some experience with you if you need to do a suture, for example, because I think this is one of the most advanced abilities to acquire in hip arthroscopy. You should at least have one expert near you.
And what pathology, like is it a femoroacetabular impingement, and what kind of pathology, or a loose body removal, what kind of pathology would you choose as one of your early cases?
Loose bodies could be probably the easiest one, but it's quite a little bit rare to have these patients. So I think that the pincer type impingement is a little bit easier to start. The subspine type specifically. The anterior cams are easily to correct too, but I think you should avoid a case like that I showed with a lateral type pincer and lateral type cam. These are a little bit more difficult to understand and to give a good correction.
And Thiago, you know what, in the elbow, there is a stratification for the level of difficulty. Okay, so level 1 is for the easy one, and someone has published on that. They've looked at the 4 or 5 levels. So is there something on the hip like that? Level of difficulty, okay, level 1 is going to be a loose body removal, and a level 5 is going to be a labral fixation. Is there something?
I see. We don't have anything formal to my knowledge, but we usually start with our trainees by doing the portal, then by doing the capsulotomy, then they proceed to the osseous correction, and then for the suture. It's like a step learning curve. Is interesting. It's not continuous.
And do you use a pump always, or do you use gravity assisted?
For the hips, you have to use pump in every case. You cannot get a good distraction without the pump. It's mandatory.
Thank you for that. And have you had an experience? You've discussed about the pudendal nerve pulse, paresthesia. So have you had an experience of the pudendal nerve palsy, and how does it present actually because of the traction?
The femoral palsy?
No, the pudendal nerve.
The pudendal nerve, yeah.
The perineal post.
Yeah, I changed my technique, I think about 6 or 5 years ago. I was an inside-out guy, then I'm outside-in. I have no more cases of transient praxis. I think that with the previous technique, the inside out, which is the most classic technique, most used probably, you have too much time in traction, and this could be a problem, especially in those muscular guys.
And how does it
force?
How does it present? What is a clinical finding?
It can be present as numbness on the groin, or sometimes even with sexual problems.
And
but they are
it's
transient.
generally a transient one, right? It is not a permanent, isn't it?
They are quite always transient, luckily.
The other question is, you mentioned about the abdominal compartment syndrome. So
yeah.
How does abdominal compartment syndrome, present, and how do you really suspect, okay, there could be a risk of abdominal compartment syndrome? Abdominal pain could be one. What are the other things that you need to keep in your mind, like, and inform your general surgeon?
Yeah, it will present as cardiac arrest, because the pressure on the abdomen will be so high that the patient will go into a shock, cardiogenic type shock. So if you are doing an arthroscopy and the patient start to getting bad, probably something's happening. The signs you have is abdominal distension. The pump could not keep the pressure, so it's rare. You should always use the lowest pressure you can on the pump. And if you're gonna do a psoas stenotomy, do it at last time of the surgery, because the psoas connects to the retroperitoneal space and could be a path for the fluid. It's very rare. I never had one case. I heard about one case in my city. It was not fatal, but it's complicated. It's a very, very bad complication.
Okay, Thiago, I think that's all the questions that we have. Thiago, thank you for this fantastic lecture. Great learning, a lot of new insight, and we'd love to listen to you once more later.
Thank you so much.
Thank you very much.